Uh, Thank you, sir, for the kind words. Good afternoon, everybody. Today, the term is a little different, but the drugs may be familiar. It's just a combination of two drugs together in the management of diabetes and obesity. In this aspect, I plan to cover, in the constraints of time, two particular drugs, and the first one I'll talk about. Actually, in a recent study given by Mohan et al., they found the average blood sugar control is very poor, and it's at present 8.56% HbA1c in India. More than 69% of the patients, according to ICMR, are above 7%, 54% are above 8%, and quarter are about 10%. And despite EADA and EASD having targets of 7 and less than 6.5. So the traditional approach is to start with the diet and exercise, start with monotherapy, combination therapy, then go to basal insulin, multiple doses of insulin, etc. But in this process, we waste a lot of time and then try to lock the stable after the horse has bolted. So, if we use combination therapy rather than sequential therapy, we can earlier achieve goals. We can definitely reduce dose-related adverse complications with high-dose monotherapy. There is some chance to delay disease progression, and you can combine multiple therapies advantageously with complementary modes of action. The UKPDS is one example of hitting hard, hitting early, and hitting at the right time. The study started in 1977 and went up to 1997, where conventional versus interventional intensive therapy were there. And after that, the patients were followed up for another 10 years, and both the groups were in conventional therapy. It was found that any diabetes-related endpoint was reduced by 9%, microvascular disease a whopping 24%, myocardial infarction by 15%, and all-cause mortality by 12%. Of course, DiFronzo has described the ominous octet from the initial triumvirate, and they find that using multiple drugs in combination based on treating known pathogenic abnormalities can be started early. If you do so, then all the aspects of the ominous octet can be attacked. For example, the DPP-4 inhibitor takes care of the glucagon, has increased incretin effect, reduces hepatic glucose production, indirectly increases insulin secretion, and whereas the SGLT2 inhibitor will act by reducing glucose reabsorption from the kidney. So, when you combine this DPP-4 inhibitor with SGLT2, these are the complementary actions. The DPP-4 acts on an insulin-dependent mechanism, reduces glucagon and endogenous glucose production. It is weight neutral. It increases GLP-1 levels physiologically. It reduces the fasting and postprandial sugar, and since it's an insulin-dependent action, there is minimal or no hypoglycemia. Whereas the SGLT2 inhibitor acts on an insulin-independent mechanism, increases glucagon and reduces endogenous glucose production, decreases weight, decreases BP, to some extent increases the GLP-1 levels, reduces both fasting and postprandial sugar with minimal or no hypoglycemia. By now, in these 2 days, you would have seen the slide many times, where this is the ADA, EASD classification in which they look at the etiology, whether you want to reduce atherosclerotic cardiovascular disease, whether you want to reduce heart failure, whether you want to reduce CKD, whether you want to minimize hypoglycemia, or want to cause weight loss or cost. In men, atherosclerotic cardiovascular disease is the main thing. GLP-1, SGLT2 inhibitors are the drugs of choice. When heart failure is there, then again SGLT2 is the drug of choice. When there is compelling need to minimize hypoglycemia, both DPP-4 inhibitors and SGLT2 are again the drugs of choice. Again, for weight loss, GLP-1 and SGLT2 are good drugs, whereas DPP-4 enzymes are weight neutral. So there are many instances where a complementary action of both these drugs are helpful. And AACE also endorses this, and they have put SGLT2 third and DPP-4 as one of the drugs after metformin. So when you combine linagliptin with 5 milligram linagliptin with 25 milligram empagliflozin, you can achieve at least 1.19% HbA1c reduction, and this is superior to any of them being used alone. And from a baseline HbA1c of 7.9, you can achieve at least HbA1c reduction of 1.2%. And if the baseline HbA1c is higher, if it's above 8.5%, up to 2% reduction in HbA1c can be achieved. Unlike a sulfonylurea, the combination of a DPP-4 inhibitor with SGLT2 inhibitor will ensure a durable action, as this study for 4 years showed a persistent reduction of HbA1c. And there's much more chance of reaching the goal, as nearly 2/3 of the patient reached the goal in this particular study when combined 25 milligrams of empagliflozin with linagliptin. So in this Asian study, when compared 10 milligrams linagliptin and 5 milligrams linagliptin and 25 milligrams empagliflozin, the reduction was much better. So does this offer any other pleiotropic benefits? Yes, because of the linagliptin will be weight neutral, empagliflozin will cause weight loss, and together there is at least about 3 kilograms weight loss in a patient who's on metformin alone. And due to the effect of osmotic diuresis caused by the SGLT2 inhibitor, there is reduction of the systolic and diastolic blood pressure, although a small level. The EMPA-like trial has been discussed, showing great cardiovascular benefit for empagliflozin. And recently, both the Carmelina and the Carolina trials have shown that linagliptin is very cardiovascular safe and neutral. So this combination in turn will rather prove having a lot of cardiovascular safety and to some extent cardiovascular benefits. And the EMPA-REG and both the Carmelina trials showed that both these drugs have renal benefits in incident and worsening nephropathy and timing to first occurrence of albuminuria. The adverse of both these drugs have low hypoglycemic action, and so the combined hypoglycemic potential is at 1.8%. This is another significant thing. One of the most common side effects with empagliflozin is the presence of genital and genitourinary infections. Now, when DPP-4 inhibitors are combined with the empagliflozin, it's been noticed in many meta-analyses that the incidence of genital infections and incidence of genital urinary infections are much less. The postulation is there is inhibition of the DPP-4 enzyme in some bacteria and fungi, and this would cause less infections. So, to summarize, 10 benefits are there with EMPA and LINA, the combination. It addresses multiple pathophysiological effects. There's high efficacy in reducing HbA1c, early achievement of goal, significant weight reduction, diastolic and systolic blood pressure reduction. EMPA has cardio-renal protection and CV death reduction. LINA has CV renal safety and reduced potential of genitourinary infections. Also, you would have noticed the SGLT2 inhibitors increase the glucagon, whereas the linagliptin will block the glucagon. So, glucagon may be the source of ketoacidosis in when SGLT2 inhibitor is used. So, this combination also will see there is much less incidence of euglycemic ketosis when compared to using SGLT2 inhibitor alone. The second compound I'm going to talk about is a GLP-1 analog and basal insulin in a single device. That is liraglutide plus degludec in a single device. This is known as ID-Glira. So what's the rationale and what's the development? This is not yet come to India. When you start a patient with basal insulin, generally the thing is, that's it. Both the patient and the doctor forgets about it, and he continuously starts raising his sugar after that. Why is this so? Because the doctor does not realize that diabetes is a progressive condition, and this combination will work initially only for some time. But after a time, the postprandial will start rising, and just plain basal insulin with oral hypoglycemics will not do the trick. And as you keep raising the dose of the glargine or whatever basal insulin you use, the sugar may not get controlled. At the same time, there is more chance for hypoglycemia. So, as regards glycemic control, most patients are not on target. There are more hypoglycemic events when you try to control the sugar simply by raising the dose of the basal insulin. The more insulin you give, another side effect is the patient is going to put more weight. And shifting to multiple complex regimes like basal bolus, while sounding attractive, while sounding physiological, may not be agreeable to the patient, and the patient may find it more complex. So, what to do? So, this is a combination, that is GLP-1 receptor agonist plus basal insulin in a monotherapy. Both will help reduce HbA1c. Both will help reduce fasting sugar. The GLP-1 analog will control the postprandial in addition to fasting. Because of the insulin monotherapy, patient will gain weight. When combined with GLP-1 analog, the weight gain is minimized or may cause weight loss. And GLP-1 analog has the least hypoglycemic action. But the only extra side effect is the nausea which may come with the use of GLP-1 analog. GLP-1 analog will have action on the heart. It's cardiac protective, as the leader trial showed. It's having a glucose-dependent insulin action and also glucagon action. It reduces hepatic glucose output and also reduces gastric emptying. Whereas the basal insulin will act at the skeletal muscle level, will act at the hepatic level, and also at the adipose tissue level. So, this combination will have a scientific basis. The basal insulin analogs will control the fasting sugar. It will be simple to initiate. It can, by itself, will reduce the HbA1c by 50 to 60%. However, it can lead to more hypoglycemia and may cause slight weight gain. Combination of GLP-1 will attack the postprandial sugar, control the HbA1c, least risk of hypoglycemia, and weight lowering effects. The same slide which was again shown, again for atherosclerotic cardiovascular disease, GLP-1 analog is the drug of choice based on the LEADER trial. And basal insulin is used as a second or third line in all these situations. This is not moving. Now, there are many meta-analyses which have been combining basal insulin with various types of GLP-1 analogs, and including they've tried glargine, they've used degludec, they've used liraglutide, exenatide, and albiglutide. All these together have shown fairly good results. Let us have a few words on this BEGIN trial. Here, this is a 2-year-old trial where they compared 3 groups with the baseline HbA1c of above 7. That is liraglutide with degludec plus metformin, one group, degludec with single dose of aspart, that is the basal plus therapy with metformin, another group, and degludec plus metformin alone in the third group. They found that the IDEG plus lira plus the basal IDEG plus single dose of aspart therapy, there was somewhat similar reduction of HbA1c. But the IDEG lira group showed much better reduction of weight, less hypoglycemia, and less nocturnal hypoglycemia. More patients in the IDEG lira group achieved HbA1c, and there was less hypoglycemia and no weight gain. So what can we expect when we combine GLP-1 analog with basal insulin in one pen? Efficacy-wise, the basal insulin will help reduce HbA1c, fasting blood sugar. The combination of the GLP-1 analog therapy will help reduce postprandial sugar and reduce HbA1c. The side effect of just basal insulin is increased weight. That will be minimized by adding GLP-1 analog, and so is the hypoglycemia, which is minimized by addition of GLP-1 analog. But however, nausea is indeed a side effect, and if the patient can bear with the nausea for the first 2 weeks, then this combination is a win-win combination. There have been trials on IDEG lira development. They used it, these were known as the dual studies. Dual 1, where it was an add-on to metformin and pioglitazone. Dual 3, where switched to IDEG lira from just plain liraglutide therapy. Dual 5, where switched to IDEG lira from glargine versus continuous titration of glargine alone. IDEG lira, when compared to either plain degludec or plain liraglutide, showed up to 1.8% reduction in HbA1c. When switched from GLP-1 analog, IDEG lira combination showed an extra 1% reduction in HbA1c. And when switched from basal insulin, again almost 1.1% further reduction of HbA1c. And as an add-on to OAD, it was found to be more advantageous than adding either ID-Glira or just adding only Degludec or liraglutide alone. And when switched to basal insulin, from basal insulin, when this was added, much more patients achieved HbA1c than with basal insulin alone. The rate of hypoglycemia was very comparable with much less than Degludec by monotherapy, but higher than liraglutide monotherapy. Body weight reduction, when compared to Degludec causing slight increase in body weight, liraglutide causing good reduction in body weight, this was somewhat intermediate. Similarly, when plain liraglutide was used, there was reduction of weight. When this drug was used, there was slight increase in weight. And when compared to basal insulin, it showed much less increase in weight, in fact 1.4 kilograms reduction in weight. Another combination trial which they had was Dual 7, where ID-Glira plus metformin was combined with 3 doses of insulin aspart plus glargine plus metformin. That is, they combined a single shot with basal bolus therapy in 26 weeks. There were 250 patients in this group, and the study lasted, as I told you, for 26 weeks. Both these groups achieved somewhat equal reduction in HbA1c, but the reduction of the total insulin dose was far less in this when compared to multiple doses of aspart with glargine. And the proportion of patients receiving the endpoint were comparable in both the groups, but the weight gain was not there, the hypoglycemia was not there. So this ID-Glira scored over the basal bolus mainly by reduction of weight and superior reduction in the rate of hypoglycemia, and also nocturnal hypoglycemia. So to summarize, insulin and GLP-1 analog therapy in a single device complement each other well and is well tolerated. Several trials have concluded that better glycemic control with lesser risk of hyperglycemia and simultaneous weight loss can be achieved by these molecules. ID-Glira has further simplified this combination in the therapy as evident by the phase 3 clinical trials. Once daily ID-Glira is non-inferior to basal bolus therapy with better composite outcomes and lesser insulin dose requirement, while simultaneously offering the multifactorial treatment approach. I thank you all for a patient listening. And the cost is not yet known, but each device will have one unit of Degludec with 0.36 milligrams of liraglutide. So you have to start with 10 steps. 10 steps will give 10 units of Degludec with 0.36 units of liraglutide. Since it's not yet marketed here, the cost is not fixed.
How often do you have to titrate the dose? How frequently? Upwards?
Usually once a week will be right. once a week will be right. See, for example, if you're starting first without as a new case, you can start with 10 units, that is 10 steps. But if the patient is already on some other insulin, you want to change the insulin, I think the starting dose will be 16 steps. And then thereafter, maybe once a week we can titrate.
Each step is 1 unit of insulin plus?
Each step is 1 unit of degludec plus 0.36 units of litaglutide.
Any questions?
10 units is 10 steps, sir. 0.36 into 10 will be 0.03 will be 3 points. Sorry, 0.036 will be 0.36.
Sir, like this combination, you have GLP-1 receptor agonist, GIP receptor agonist plus glucagon. All three things are together. There is a combination is also coming up.
It's just the device. Initially, GAP was not thought to have any big role, but now they realize that it also has a role, especially in reducing the hypoglycemia. So these are in phase 1 and phase 2 clinical trial stages.